So we're going to be covering prescribing Sativex for spasticity and establishing shared care in your local system, but also covering spasticity as a whole. So I'm Joela, I'm the pharmacist at Barts Health, and Rachel is my co-presenter, and she is a consultant specialising in spasticity and works at Queen Square, UCL. Rachel, over to you.
Great, okay. Sorry, just fixing my slides. So hi everybody. Yeah, I'm really delighted to be taking part in this today, as Joela has said. Hopefully some of our experiences will be able to help you set up shared care so that people in your area will be able to access the treatments that are appropriate for them. Hopefully most of the participants are in now. So as Joela said, we're going to do a short kind of presentation, a review of spasticity and how Sativex fits in the paradigm, talk a little bit about the experience that we've had at our centre. We've been fortunate to be able to use this medication for 10 years now. And hopefully that'll frame it for people in a local area as to how they might set up their services, what to expect when using this medication, you know, when to introduce it for the individual patient, but also what happens if they don't respond to it, you know, and how we manage spasticity as a whole. So these are just a few disclosures for both myself and Joela, who've worked extensively with companies across MS, not just related to spasticity, but including GW. So it's really good just to think about, you know, what are we talking about when we think about spasticity, because what a patient experiences and the symptoms that they have, you know, can sometimes be, you know, misunderstood, that weakness and heaviness for them feels like a stiff leg, but actually for us, we wouldn't be introducing spasticity medication. So I think having a framework to diagnose spasticity, to identify it correctly is really key. And for me, I think the velocity dependent component is the really important feature to this. So when you start moving somebody's limb slowly, you might feel a little bit of resistance, but when you move it more quickly, then the resistance increases. And that tells you there's a neural component that can be modulated through pharmacological means. There's lots of other reasons people might have stiffness, particularly as MS becomes more advanced. They may have changes in the connective tissue or the muscles with contracture formation and shortening. And, you know, this type of change can occur very quickly in somebody, particularly if they're immobile. So think of the person with a foot drop, for example, and if they're not exercising and stretching their ankle, these changes will occur quite quickly. But this will not change with velocity. So whether you move the joint through range quickly or slowly, you would feel the same type of resistance. So it's really important to differentiate what is the neural component and spasticity and what is non-neural, because how you're going to treat them are quite different. It's really important to think about what the impact of spasticity is on the individual person and what the goal of treatment is. We don't treat it just because spasticity is there. We treat it because it's actually causing a problem for them. And it is one of the most common features or common symptoms that people with multiple sclerosis experience over time, with about 70 to 80% of people having spasticity, and about half of those will have moderate to severe spasticity. So this can reduce function, both from the upper limb perspective or impacting mobility. It can be associated with pain, particularly if there are spasms. It can lead to secondary complications such as contractures, pressure ulcers, interrupted sleep, which will exacerbate fatigue, for example, and also spasticity is the basis of an overactive bladder. So let's think about the paradigm of where Sativex is going to sit within the treatment of somebody with MS-related spasticity. And I think what's really key is that you need a multidisciplinary approach to managing this. You know, the key people involved in the team will obviously be the doctor, be that a neurologist or a rehabilitation medicine specialist with an interest in spasticity, an MS nurse or a spasticity nurse, and a physiotherapist. Ideally, you would have access to an occupational therapist as well, if they're not embedded in the team, but somebody that you can reach out to help as well. And I think, you know, it's really key to think about the aggravating factors. So is there something that's driving spasticity or spasms? Does it occur at a particular time of the day or night? Is it associated with movement and transfers? Is it associated with, you know, passing urine or bowel movement? is it associated with having a urinary tract infection? So we think about all of these triggers and we try and modulate those, and really working with the individual person with MS, try and optimize self-management so that they know if they stretch and follow their exercise program and they make sure that they avoid or treat urinary tract infections early, maybe their spasticity will not be as severe. However, many people will need a pharmacological intervention. And then we look at whether it's just a focal area, so an ankle, a foot kind of, plantar flexing and spasming, or whether it's a very generalized pattern. If it's focal and there's any limited muscles, we can use botulinum toxin, which is a very effective treatment. But if it is more widespread, we often use oral medications. And I've listed here some of the first line agents. We kind of go through a treatment paradigm and have a plan. So you see somebody and say, well, we'll try this first. If that doesn't work, this will be the next step. And usually we'll give a comprehensive plan of all the different stages so that if it's not a full MDT, seeing the person the next time, the plan is already there to move to the next step. And really for Sativex, we reserve that for people who have failed at least 2 of the first line treatments. It's usually used as an add-on therapy. So we don't necessarily discontinue the medications they're on, we will add it on. Over time, then we will look at trying to minimize the number of drugs that people are taking and any side effects they get from them. It's also really key to know, is there a complex specialist spasticity service nearby? Because if people don't respond to Sativex, which is about 50% of people, we need to think about what happens after that. Now, I'm not going to go into all of those details, but there are intrathecal therapies, for example, such as intrathecal baclofen pumps or phenol, which can be really useful as well. So let's focus a little bit on cannabis so we know what we're talking about. So Sativex is a licensed drug. However, when patients think about cannabis and cannabinoids, what we're talking about are the derivatives from the cannabis sativa plant. And there are so many, there's over 120 different cannabinoids identified from this compound. So the 2 here are the ones that are most commonly known, and they are what are in Sativex, so CBD and THC. So why do we use cannabinoids and why are they of use to people? Well, they interact with the endocannabinoid system, which is the body's endogenous system, of cannabinoids. And there are receptors for these expressed throughout the brain, the spinal cord, in muscle, in the bladder, and also on immune cells. So actually their use and function is quite widespread. In general, they modulate kind of anxiety and relaxation, appetite, sleep, memory, and also have a role in stress regulation and possibly neuroprotection. And I think what's key to know about cannabinoids is, whilst they're highly expressed, for example, in the cerebellum and through the temporal lobes, there are very few cannabinoid receptors in the brainstem, particularly in the medulla, and therefore respiratory depression is not really associated with cannabinoids, which is one of the reasons that they are probably a safer agent than opioids, for example. So let's think about the cannabis products that our patients might be accessing. And really, I tend to divide these into 4 areas. So we have regulatory approved cannabis-based medicines, of which Sativex is one. And these have been through high quality randomized placebo-controlled trials and have been approved for use by regulators. We then have the non-regulatory approved cannabis-based products. And this is what is being discussed quite a lot in the media, for example. These have not been through randomized placebo-controlled trials. They are not approved as medicines by the regulators, but they are produced to a medical grade. And these are incredibly expensive products. These have been reviewed in the cannabis-based medicinal products guidelines, which were concluded in 2019 by NICE. And actually, there are no trials, there was no evidence to support it, and they were also very expensive. And then we think about the CBD containing products. And these are the agents that many people with MS are accessing, either purchasing online or through kind of health food stores, for example. And these are not regulated. They're produced in line with food standards as opposed to medical grade standards. And therefore we don't know exactly what's in them. They should have less than 1% of THC in them to be able to be considered a food supplement. But again, you know, they're not regulated. And then we have recreational cannabis, which, you know, I think about 20% of people with MS will use cannabis. This obviously is used through kind of vaping, smoking, ingesting, making edibles, and it is used, you know, it's not regulated. We don't know what's in it. A lot of it is produced illegally as well, and is grown to have a very high THC content at times. So we need to be very cautious about this. And I always say somebody's using, you know, this type of cannabis medicinally when they use a small amount in the evening, for example, to help with sleep and spasms and nocturnal symptoms, but they really don't like using it during the day. And this obviously is Sativex. So there's quite a lot of interest in cannabis-based products in multiple sclerosis, and anecdotal reports where, you know, cannabis helped with symptoms. And this has underpinned all of the kind of the trials that have occurred. And there've been about 13 trials looking at cannabinoids to treat spasticity in MS, and really one, the pivotal trial in 2010, the Novotna study, which showed an impact. So the journey of Sativex then from, you know, having kind of a 15-year phase of development approximately through to being licensed in the EU as an add-on therapy, and then was initially reviewed by NICE, but not deemed cost effective. So for the majority of people in the UK, for the last 10 years since it's been licensed, they have not really been able to access it on the NHS anyway. So we were very fortunate in our service. So Val Stevenson, who's our clinical lead, suggested that we might use it in people who, when you think about the treatment paradigm, they'd failed all the first line treatments and they were proceeding with intrathecal therapies such as intrathecal baclofen. And would Sativex reduce the need for people having invasive procedures? So this was how we negotiated to be able to use it within our service. So this gives a framework of how we ran the service over the last 10 years before shared care has been agreed. So we would see them as an MDT, review everything to do with triggers, their self-management, their physical program, what medications they had tried, what doses they had used, and whether they had side effects or what happened with it. For those that we thought Sativex was appropriate, we would examine them obviously to confirm that they do have spasticity, but then we use some of these patient-reported outcome measures. You'll see here the NRS, the numeric rating scale, which is a 0 to 10 point scale, where the individual rates how severe their spasticity is. So 0 is no spasticity whatsoever, 10 is the worst possible, and you ask them to reflect over a 24-hour period. You can obviously alter the timeframes for that. We also used a questionnaire called the Multiple Sclerosis Spasticity Scale 88, which is a kind of 88-item questionnaire that is divided into sections, each which can be used independently. And it really gives a very thorough overview of the impact of spasticity on the kind of level of functioning and symptoms of somebody with MS. So we use both of these because the NRS, it's quite a simple scale. And actually we thought the MSSS 88 would give probably more valid kind of data to show the efficacy of Sativex. So for our service, we would educate the person about how to administer the spray, how to find the right dose, you know, and how to kind of what time of the day to take it. We had a nurse-led telephone review at 2 weeks to try and support somebody in their dose finding, troubleshoot any problems with administering it and the times that they might take it. And then a face-to-face review at 4 weeks, which was physiotherapy-led for a hands-on assessment, but also to review how the patient was managing. If people were really clear responders, you know, had found their dose and we weren't that concerned, we would then follow them up every 6 months. But for some people who weren't sure whether they, you know, whether it was effective enough for them, you know, where they weren't kind of clear-cut responders, we might see them at 3 months. So I'll just go through some of our data and then we'll be able to talk a lot more about the shared care guideline. So we have probably treated about 350 people, but a lot of these people then have discontinued the medication within the first kind of few months, or else they, in the last year or so, for example, they've only recently started it. So it doesn't really give the picture that I think commissioners want to know is, if we start this in somebody, how long are they going to stay on it? How many people are going to stay on Sativex? And therefore, what's the cost for the CCG going to be? So what we've done to look at our data is we've selected out people who started over 2 years ago so that we can see how many people would stay on it long term. So because of this, we've included 223 people. You can see their age, gender, ratios there. So very typical of a kind of more advanced MS group of patients. We did have some people who weren't on treatment at the time that we started Sativex, but that was because they had tried them and had such side effects where they were ineffective and they didn't want to stay on them. But as you can see, the majority of patients then, sorry, my percentage I think is wrong there. The majority of patients, about half of them, were on 2 or more drugs, and some people were on 3 or 4 medications and still not getting on so well. Their baseline NRS was 7 out of 10, so this is, quite severe spasticity. So with the NRS, 0 to 4 is kind of mild, 4 to 7 moderate, and above 7 we consider more severe. And then you can see we don't have the exact DDSSs, but we divided them into those who could walk and those who were non-ambulant. And that's kind of, you can see it's quite an advanced population. So I think this is quite interesting. So this is really what happened with all of these subjects who we treated. So within the first few weeks, we had quite a lot of people, 36 people discontinued, mainly due to side effects. So dizziness, feeling sedated, feeling anxious, or just not feeling right, and they didn't like it. Some people didn't like the taste and found it uncomfortable spraying it into their mouth. So by 4 weeks, 160 people had come back and were deemed responders. So quite a high number. But as you can see, we continued to lose people. So by 3 months, it was down to 136. So about kind of 60% of people appear to be responders. And I think this is really in line with the real world data, which is slightly different to an RCT finding. But what you can see is that by 2 years, we have 80 out of the initial 223. So this is just under 40%. But once people get to kind of 6 months, the amount of people who are dropping off, it reduces and you just get a bit of a steady state. So we do have people who are long-term responders. And in our cohort, we do have some individuals who have been on it for, 5, 6, 7 years. We also saw, so using the NRS, that 0 to 10 point scale, that there was a really clear response that was maintained over time. And this is actually an analysis we did looking at the entire cohort, which went up to 5 years. So the people who stayed on it and were, NRS responders, they kept that response long term. And similarly with the MSSS 88, again, this response was maintained. So it's not going to work for everybody. It won't be effective enough for everybody, but for a cohort of people, they respond really nicely to it and can be long term. So I think it's useful to think about the clinical guideline. So this, and I think this is an area where if you're searching for the NICE guidelines on multiple sclerosis, you're not going to find the cannabis guidelines. You will when you look through it and you see the section on symptom management and rehabilitation, and there is a link to this NICE guideline, but then you have to go into that, find the specific bit about spasticity and the section on Sativex. So it probably is a bit more involved and people need to know to go looking for this, because in the cannabis-based medicinal products guideline, we looked at chronic pain, intractable nausea and vomiting, spasticity, and treatment-resistant epilepsy. So it was a really extensive guideline. And out of it, from the spasticity perspective, the only cannabinoid that was recommended is Sativex. And in this recommendation, there's also guidance on the shared care agreement that should be set up. So it was recommended by NICE that this would be prescribed under shared care. And there's a framework also provided in that. So this is the link to the NICE guidelines. This can be probably shared in the chat or afterwards, and I can say that people can have access to that. And also on the basis of these guidelines, led by Val Stevenson, our clinical lead, our hospital has entered into a shared care agreement, which was approved last November in North Central London. and you can have a look at that as well. You know, I think it's quite a useful document to base your own shared care guideline on. Apologies, I haven't changed my X, but I believe that there's about 7 CCGs that have now approved it, and I know there are others who are in path. So I think for people who are prescribers and treating MS spasticity, I think it's really key to, you know, to move with this and to support your local patients. And for people with MS, even though it's frustrating, you know, a little bit of patience is going to be required before we can roll this out on a national level. So I'm going to, lastly, I'm just going to say that some of you may have seen this poster. Actually, Liz Keenan, our lead CNS for neurodisability and spasticity, led on this poster. And we thought, great, we've got a shared care agreement now for North Central London, and we've 109 people still on this drug that, you know, we want to enter into shared care. But then we realized only 9 of these were in North Central London. And we were actually treating people from all over the country. So we probably have a vested interest as well in trying to move to shared care on a national level so that people don't have to come up to London to access this treatment. So I think I'll leave it there and hand back to Joela.
No, so thank you. That was really useful, Rachel. And I think it's really important to get the background information about why you do want to have this as shared care written. So it isn't just, oh, we want to be able to prescribe Sativex. You want to be able to treat patient spasticity and have the whole pathway approach to the symptom. So then you can actually engage with your commissioners and saying, actually, we need a pathway approach to this symptom so that we can manage our patients appropriately. For those of you that don't know what shared care is, so Rachel's mentioned it, you'll have heard things mentioned, and obviously the example from UCL Queen Square is, I put the link up again because it actually does help a lot of conversations, because a lot of conversations with primary care commissioners, etc., is that, or is anyone else doing this? Like, they want to know, no one wants to be the first. Well, actually, we've got a North Central London CCG has approved a shared care, so there's one that people can view. But what is shared care? So the responsibility for prescribing between primary and secondary tertiary care, so any specialist might recommend any drug for a patient, but often that specialist can't see that patient every time the repeat prescription needs undertaking, so every 4 weeks. Now, if you're in cardiology and you're recommending simvastatin, it's low risk, low monitoring. Most GPs are fully aware of high cholesterol and what you're meant to be doing. You don't need a shared care because it's there's enough patients with that in a GP practice that you don't need shared care. But when a condition is more rare, and if you think for each GP practice, so Rachel shared that she had 9 patients in the whole of North Central London. Well, imagine those 9 patients aren't coming from the same GP practice. There's probably 9 different GP practices. So each GP practice has less than 1 patient that might need this medication. So they can't learn about all of these different medications. They need some help and guidance on how to treat these patients. So the NHS England have said that if the clinical responsibility for prescribing should sit with those professionals who are in the best position and appropriately skilled to deliver the care which meets the needs of the patient. Now in the world of spasticity, it would be great if all patients from around the country, as you can see from Rachel's map, could carry on, go to see the specialist spasticity service at Queen Square, and they undertake everything for those patients, and they were appropriately reimbursed for that service, and the service grew. But that isn't practical, one, for the patient, because if you're living, to be honest, even in Tower Hamlet, which is the CCG next to Queen Square, it's actually quite difficult to get to Queen Square every time you have an appointment and the repeat prescription required. But actually the GP might be down the road. So is it more appropriate that the GP takes on the prescribing and is given guidance on how to monitor the patient and when to refer back to the specialist service? So Rachel's team, they've got a North Central London shared care agreement, and that's great for the patients in North Central London. And in the old days of PCT, so this is going back about 3 NHS's structures ago, a host PCT could agree a shared care And it was determined that if a patient then went to Queen Square, a patient that didn't live in their host PCT should honour the host PCT shared care, because it's been gone through the formulary applications, and actually Rachel couldn't apply to for every PCT in the country to say, will you agree this shared care, but it would be honoured. That is different in the world of CCGs, but no one has really challenged it, and people have followed that same rule. And going on to ICSs, it will be more local population-based health. So in theory, those Rachel's patients that are coming from elsewhere and other CCGs or ICSs will be in the future than North Central London, they don't have to agree to the shared care. They can say, well, actually, Rachel, you saw the patient, you wanted this medication to be used, we're not prescribing it, which isn't the best care for the patient. Rachel isn't prescribing this medication because she wants the patient to have the medication. She's doing it to treat the patient's symptoms, and it's appropriate for them. And what is, I think, really difficult is managing those expectations. So patients often, and I presume, and clinicians think, oh, well, we'll send patients over to Rachel and she'll prescribe Sativex and that's what they're going for. And two, it will cure all spasticity and, from day one. But we can see from the graph there's actually quite, although it's quite a high response rate, and once you've got over that 2-month mark, if you're responding then, you're likely to respond in the long term. There is a drop-off rate. So people need to be aware.
I think that's a really good point, Joela, because both Val and myself, it can be tricky if expectations are set too high. And actually, since we've got the shared care agreement, because that's in place now, our kind of hospital board, we're not meant to initiate treatment for somebody where the funding has not been identified to continue it. So Sativex has a pay per responder system. So the initial trial pack is covered by the company, but that you have to sign a form, and it's now an online thing, that an online record where you record the details of the individual you're starting Sativex in, and detailing that funding is there to continue it. So we now are in a situation where we cannot initiate Sativex unless the local CCG has approved it. So many of you might be getting letters from us detailing that.
And that's only fair on the patient as well, because it would be really cruel that the patient starts a treatment, yes, it works for them, and then we say, oh, by the way, no, you can't have it. Like, I feel that would be quite cruel, and it is, and I think, and then they could then be open to it, exploitation by other people, etc., who then want to try and make some money from the fact that these patients then definitely want the treatment ongoing. But there are expectations not only from the clinicians that refer patients, but also the patients themselves and obviously their caregivers, etc. Like, it is a whole sort of raft of people that expect this to sort of, cure all spasticity. But so what do I think should happen? So basically, if you are sitting there in a local centre and you are not one of the named neuroscience centres on the NHS England specification, you could have a shared care with your specialist service. So you could have shared care from neurology centre to neurology centre, or hub and spoke. And so you could work out, actually, we will refer patients to our local specialist service, and they can do they can look after the spasticity, but the prescribing could go back to the local centre, because it doesn't always have to be from GP to specialist, which might be harder to implement. So you need to think about what would work in your locality. But or you could have the specialist team, because they will actually, there are a couple of GPs who have an interest in spasticity. They have a couple of patients. They could agree that they will be gypsies with a specialist interest that could take on the prescribing for their locality. It's what works in your geography. So what do you need to do to set this up? So most of us are sitting there with no shared care set up, probably no spasticity pathway. And actually, in the past, all we've done is refer to Queen Square, hoping that someone else will look after the problem. Well, actually, now we all need to look after our own population, which is right for the patient. So who do you need to get in the room? So one, go and speak to your specialist pharmacy team, because they'll know the contacts, either at the CCG pharmacy team, in contracting, in finance. You also need service managers. You need to then work out, what are you missing? So look at the spasticity guidance, look at Rachel's guidance, look at the UCL shared care, and look at who else is needed in the team. You need physios, you need to be able to measure response, you need occupational therapy, you need a named clinician who wants to be the clinician with the interest in spasticity, so they can take on some of the responsibility of presenting the case to your formularies and commissioners going forward. But it's then having the conversation about going forward, how we're going to have a pathway for spasticity. And the other group not to forget is not only the rehab within your hospital, but your community rehab colleagues, because they might be the people that are seeing these patients and you want the appropriate referrals into the service, because these patients will still need to continue to see community physio, etc. All of that service won't stop because of the Sativex suddenly being available for these patients. So you want to sort of have the whole pathway mapped out for the patient and have people seen appropriately. Don't forget, if you have any questions, to put them in the chat. So just be aware that the conversation is going to take a while. One, you all know that if you try to get a room of more than 4 clinical staff in a meeting, to get a diary, a meeting that doesn't clash with anything else, it's going to take at least 2 or 3 weeks to arrange, or at least 6 weeks if clinics need to be cancelled. So start those conversations early. Work out your named clinician. Work out is there a physio lead? Is there a specialist MDT lead that needs to be involved? Commissioning pharmacy and service managers, general managers, because in the change into the way the finances of secondary care is working and with block contracts, it does mean that if this is a brand new service, you need to negotiate a new block for this service. So it's more defined about what you're managing and what you're looking after.
See, there's one question in the chat to you, Joela. If we don't have a specialist pharmacy team, what would you recommend? We have an MS neurologist and nurse and a neuro rehab team.
So if you're in secondary care and you haven't put your name, if you're in secondary care or a hospital-based service, there will be someone responsible for the medicines in your service. So either a chief pharmacist, or it could be the medical director that has a team that is involved in the medicines. Speak to them. Your CCG definitely has a pharmacy team, so it might be that it's them that you need to liaise with, but there should be a named pharmacy person that you can speak to, because not only will, once a shared care is written and agreed, you'll then have to set up the contracts and make sure it's on formulary and all of those other rubber stamping and a lot of documentation that needs to occur. But there will definitely be somebody. If you want to email me, and if you have NHS Net, if you just search for Joela, you'll find me. It's very easy, and I can try and get you a name as well if you really do struggle. But it's getting all the right people to have a conversation and be realistic about when you expect this to happen. So if you all manage to get all the right people into the room by the end of this week, and considering today is Wednesday, if you got them by the end of the week, I'm impressed with your organisation skills. It's still going to take 3 to 4 months to get this through everything, because there's a lot of rubber stamping. But we are doing work behind the scenes. So the top link, the SPS link, it goes into what shared care is, and the regional medicines optimization committees are looking at shared care that should be written on a national level. Because although UCL have written their own local shared care, actually broadly, most shared care around the country broadly use the same template. So actually this is one that is rife for a national shared care agreement that then people can sign up to much more easily, because it's all written for you. So we are trying to get that endorsed by SPS, and then it is much easier for people to lift and shift in a way, but it still needs to be signed up to. You still need to have the mechanisms and have the pathway in place to make sure that you are able to use it. It isn't a case of, oh no, it's nationally agreed, we can just start. You still need the pathway, and you still probably need the resource to be able to do it. And in going forward in the way the block contracting and the funding of the NHS, if this is a new pathway, you do want to negotiate a new way of going forward and a new block for that pathway, but also looking at the maximum number of patients that you're likely to have, and at what should happen when you reach that number. Because Rachel, I presume when your service started, you wouldn't have been able to guess how many patients you were expecting.
So I suppose we are unusual, being a national centre. We can see people from all over the country. So we have a large volume of people coming to us anyway. We have over 200 people with intrathecal baclofen pumps, for example. So when you're thinking about when we started, it was being used so that people had, what was the option outside of having a pump implanted? So actually the numbers were quite small. So in 10 years, we've only treated about 350 people with Sativex. We're probably using it a little bit more now, because of our experience with it. Also, people being aware that we have been prescribing it and therefore referring. Whereas, as I said, unfortunately, at the moment, we're kind of in a little bit of a bind. Unless the CCGs have approved it, we're now not starting it in anybody new, because now that, we've gotten to this point. And I think that's really important, as we've already mentioned about setting expectations. I think the other issue is about, knowing that it's spasticity. And if people have neuropathic pain, we're not, it's not licensed for neuropathic pain in this country. We are not using it for pain. So if people are referring just because of pain, again, it can cause a lot of disappointment. For some patients, particularly with intractable pain, they can often be even more frustrated than, those who have spasticity about accessing this. So I think, we're getting there. A lot of progress has been made. It's positive. But, on a national level, we're not quite there yet. I was going to ask you about the idea of a kind of a national shared care guideline and how that might be addressed.
So I think one of the comments in the Q&A has been that it's taken 18 months to get a shared care agreement approved by their local committee. And that is the reason why these national shared cares have been implemented and written, because one, there was duplication of effort. So if you take something like Riluzole or something that's used in neurology, mycophenolate, and there's often shared care, every trust has written their own shared care with their local PCT, CCG, and then has to get them approved and reapproved every so often, depending on your length of approval. But actually, they're probably very similar to every other shared care for mycophenolate in the country. So why was there this duplication of effort? So that's why they're being written nationally and approved nationally, so that they can then, it's much easier to lift and shift. And although the national guidance is that shared care should be per condition, and obviously for Sativex and spasticity, that's very easy. It's one medication that's used in one license indication. But actually for other things, the actual shared care is written for the drug. Because if you're using mycophenolate in renal transplant, or you're using it in other conditions, you're probably actually, the monitoring, etc., is the same. So actually that's one of the reasons, is to stop that duplication of effort between centres, between specialities, because I know in our centre, we would have 5 or 6 shared care guidance for methotrexate, depending on which clinical speciality was using it, and it didn't make any sense. And often everyone would pick the wrong one, because the idea is a shared care would be printed out for that once it's been agreed for the patient in front of you, signed by the consultant or the specialist, and that could be the specialist nurse, specialist pharmacist, specialist physio, but they're under the direction or they're working under a specialist consultant, and then sent off to the GP. The GP then also signs up to it. But there's also responsibility for the patient. So the patient has to notify usually the prescriber or the specialist team if certain symptoms occur, or for the monitoring. In case of Sativex, that includes response, but also for the community pharmacist. So for Sativex, it is a controlled drug. So it has all the controlled drug prescribing regulations required it. It's also a fridge item. Also, there is a responsibility for the patient to not wait till they've run out of medication before turning up and saying, I've run out, I need it in 5 minutes. And those of you that are pharmacists on the call know that will happen more times than it should. And those doctors that have to write those last minute emergency prescriptions, you're always like, how did they not notice that they were running out? But sadly, it will still happen. But there is, community pharmacies aren't going to have this in stock. It's going to have to be ordered in. So you do need that responsibility of the patient to be organised or keep a note and be able to monitor their usage. With Sativex, we encourage people to monitor their usage anyway, so that you're able to tell how the patient is responding. And in those ways, it is easier to work out when patients are going to run out, etc., and to get in contact with the appropriate prescriber. And in the terms of Sativex, it might be that actually there might be only one prescriber per GP practice that's willing to prescribe it, or that is deemed they can prescribe it. So you do need to be careful. It might, whereas a lot of the other repeat prescriptions might be done by independent prescribers of other professions, it might be that Sativex is only done by the medical GP. So you do need to be careful with that.
Yeah, I was going to comment on that, and it's alluded to in the chat, in the Q&A, that being a Schedule 4 drug, it does need to be initiated by a medical consultant, not an independent prescriber. Now, the prescribing can be carried on by the independent prescriber afterwards, but the initiation needs to be medical. And we were very careful in the guidelines to ensure that we didn't just say, you know, an MS neurologist, because actually a lot of spasticity is treated in rehabilitation centres or units, and sometimes it's treated better. You know, I think it can sit with either, as long as they have that expertise. And, you know, for neurologists who maybe don't have access to that level of rehab, you know, linking with physios just to ensure that they're, you know, from the hands-on assessment point of view, you know, identifying spasticity appropriately. So working with their physio, for example, can be really useful. You know, there was another question as well about community services. And again, I think it all comes down to having the specialist prescriber to initiate the treatment.
And it's engaging the community as part of your pathway. So the whole pathway should include everybody that's involved in this patient's care. So that will include your community team, your physios, the GP. And it might be that actually you think, well, actually, locally, there's going to be this one chemist or this that's going to be involved. It might be that you want to involve them. And don't forget, there are obviously the community-based physios, etc., that are attached to GP practices that often see these patients, because it's not only about the continued care, but it's also getting the appropriate referrals in. Because what happens, and we all know, any brand new service, you will then be flooded with patients that are inappropriately referred in because people have heard of this new service. So you want the appropriate referrals in to make sure that the patients you do see are appropriate and have gone through some of the steps beforehand that you would like the primary care or the non-specialist service to be able to manage. Because I'm sure, Rachel, you get patients that are referred in, you say, why have they done nothing? They could have done some of these steps beforehand.
Yeah, it is interesting as well, because, you know, I think it's really key that obviously this was approved in November 2019, and here we are, you know, June 2021. However, we've had a pandemic, and I think everybody's resource and energy, you know, was taken off it. So, you know, at our trust, they had started the process, and it took quite a long time, you know, before it ended up with approval. And we even had a debate of, well, what can we do now? Should we start trying to, you know, get people moved over to shared care? And this was back in kind of, you know, November. And obviously then there was another wave. So I think, you know, it's been a really challenging time. And, you know, I think that's one of the reasons we've had a big delay in this. But these things will take time.
But also, I think it highlights, actually, is it appropriate that patients are coming from all around the country to your service when there could be a service locally managed and set up? So the pandemic, although it has caused delays, it's also opened questions of people thinking, well, actually, care close to home, which has been in the NHS leadership documentation for, like, it feels like over a decade, hasn't actually really happened. There's still been services miles away from the patient's home, but actually the pandemic has highlighted the need for that and the appropriateness of patients traveling across the country to basically pick up a prescription of some medication.
And just one clarification as well, obviously it can be initiated in the community if the specialist prescriber is in the community.
Yeah,
that was what I meant by that. But it's about, you know, who initiates the first prescription, and then thereafter any kind of independent prescriber can continue.
Yeah, and that's how you'd want, most shared care works that way, is that the initial prescription, the response to the treatment is managed by the specialist. So either the specialist consultant or their team, so and then the ongoing prescribing is undertaken by the GP or the non-specialist service. to ongoing monitor the patient, to check that they're managing, but also an ability to refer back into the system if needed. And that's what's needed, is you need a way in, because what they don't want to be done having is, if you are a non-specialist in something, you have these patients, you're prescribing this medication, they're having either a side effect or their response is changing and you don't know what to do. You want to weigh in and to be able to contact the team and find out, what do we do next? And so often it might be, well, actually, we will spell some of this out in the original shared care. We might say, how do you dose escalate? How do you monitor and maintain the response for the patient? What dose can you go up to before referring back in? Because you don't want every single little query. And so side effect management might be included in your shared care, and so you don't need to sort of be called for everything, but also there is a way in if needed. And it is that access to the specialist team. But what you don't want it to be like Rachel's personal email address, because then what happens when she's off? It should be a team approach to these things, because otherwise that's when people worry. They're saying, well, actually, we don't really want to take this on because we won't know what to do.
No, absolutely. And I think, as with any medication that you initiate or prescribe for somebody, they need a point of contact, where they can, if there is any significant side effect, or as you say, they're running out of treatment, or that they have a point of contact and that they know. So thinking about the roles and responsibilities, obviously the person with MS using the medication is at the center of that as well, to monitor, self-monitor, manage their spasticity, keep an eye on how much medication they have, store it in the appropriate way, try not to lose it. It's quite easy to lose a small little vial like that. So, and I think it's interesting to think as well about, the dosing, but also the administration. So you do need to be able to have enough hand function to actuate it if you want the flexibility of self-administration. And it's one of the nice things about Sativex is the flexibility. You're not told to just take it 3 times a day. We do try and get people onto a very stable dosing regime. On average, most people coming to our centre take about maybe 6 sprays on average. We'll have some who are on lower levels and some who take a bit more. We do find that people, notice kind of dizziness and sedation. So a lot of people choose to use it sparingly in the day and then cluster their doses in the evening, and it really helps with sleep and spasm overnight. So, it really has to be an individualized treatment, and, people need to be supported for that. I think you've mentioned as well, Joela, that it needs to be stored in the fridge, which is really key. However, the vial that is opened and in use can be kept out, as long as it's not, 39-degree heat, preferably. But in this country, we don't tend to get so much of that. So,
I'm just going to roll down some of the questions. So someone has asked, does formulary need to come before shared care? And I would say no, do them. If you are sitting there, you don't have it on formulary, you don't have shared care, do them both at the same time. Get the whole pathway sorted at the same time. And there's no point doing them individually, because to be honest, it's the same people you're going to have the conversation with. If they're going to agree to pay for it, they need to then agree the whole pathway. Otherwise, what you don't want is to be stuck with a medication that's on your formulary, but actually you don't have the pathway that can enable that to be prescribed and given to patients, because you're in a no better place. And as we've heard, these things can take a long time. So you do want to get the ball rolling all at the same time. And someone has asked, I think they're based in a community service, and they have a consultant therapist lead, but they don't have a medical consultant to lead the service. So how would they move forward? They don't think that their local CCG will commission it. I'm presuming you'll be associated with a specialist centre somewhere. So either a specialist rehab unit or a specialist MS centre. So speak to them, do a joint submission across your patch, across your local CCG, ICS. So it's one, so there is a named medical consultant that can be involved, and that's what is really needed for the initiation of the medication, and then the ongoing treatment, etc., could be done by your local non-medically led spasticity service. But I'm really hoping that you have someone that you can liaise with. I don't, if you email me again, I can try and find the name of the local service. Hereford, off the top of my head, my geography is not that good. And then someone has asked, how useful do we think NICE impact resource template is in terms of estimating how many people could benefit per CCG? It's based on modelling. It's based on the best information they had at the time. I think the population of each, especially in London, of each CCG has changed a lot over the last pandemic as people have moved in and out of London. So you do need to watch. The best thing you could do is try and get some local feel for that. So use it as a guide, but it's not going to be the definitive numbers. So whatever number you end up with isn't going to be, and then find out from your local patients. It could be that you use Rachel's map and her audit and say, well, actually, there's so many patients of ours have gone over to UCL. So actually, let's you at least know that your minimum number is going to be that. And that would be a useful starting point. So it might be using the two tools together.
There were some clinical questions about Sativex as well, and I suppose not wanting to deflect, but have a look at the SMPC. A lot of that is addressed from the point of view of contraindications and cautions. If people have very unstable mental health problems, or have a history of psychosis, we tend not to use it. I do have some people though who are very stable, and I contact their psychiatrist and ask what their opinion is, whether or not they would be happy with us using this medication. So I have a lady with a history of schizophrenia who's incredibly stable on a depot treatment, and her psychiatrist monitors her, and she's using Sativex. So I think it's always about reaching out, finding out enough about people, and trying to manage that. From the pregnancy point of view, it's not recommended. I think you see most of our patients that we're initiating it in are older. Spasticity becomes more common, over time. So on average, the age of our patients is about 50. There's obviously a range. We do have people in their 20s. So it's a really important thing to consider. And driving, you are allowed legally drive using Sativex as long as you take it as prescribed, and that you self-monitor as to whether or not you feel that you should be driving. And I think that's true of several different medications, such as benzodiazepines and that.
No, and I think that's really true. And you do need to be careful, and make sure, especially when people have other comorbidities. And as we've seen, it's the more progressive patients that might be benefiting. They're likely to be of the older age groups, and also might have other comorbidities. There is one other resource that we wanted to highlight, and that's on the MS Society Professionals website, part of their website, and it's the Sativex Treating Spasticity in MS, and it's got and so the link is there, and if you go in, all of their Sativex documentation is there, and that link will be included in the follow-up email. Just so you know that they have done some extensive research, they've looked at the evidence, and it should enable you to start the conversations, because obviously if you're going to email some person you've never met before about Sativex, they're going to be a bit like, why should I worry about this? But actually sending links to the NICE guidance, sending this the pack that is on the MS Society website does help, because it also has some case studies. So even if you just took some of those case studies and put it in the body of the email and say, well, actually we have patients that and this is how they benefit, but also use Rachel's map and say, well, actually we're as a CCG, you're sending so many patients all the way to Queen Square, would it not make more sense to have a service locally? I'm sure Rachel won't mind if we reduce her workload. I don't think anyone would mind that. Someone had put in the questions about succession planning, and I don't think that's an issue just for spasticity. I think that's an issue across all MS services, but you do need to make sure you have a team behind you. So if you are the lead for this, if you either the lead physio or the lead consultant with this, make sure you have a team approach to this service, so it isn't based on a named individual. You also would ideally want trainees, etc., to come through that to gain training experience, so you do have a service that is sustainable for the long term, rather than having a service that falls apart if annual leave is taken or you have a day off or anything like that. And all of us do deserve some downtime. I'm conscious that we only literally have a minute left. Rachel, are there any last questions you would love to answer, or any points to make?
So apologies if I haven't kept up with all of those, but I think just for time, just to reiterate, I think hopefully this has been really useful for the people who've attended, and really to thank you, Joela, thank all of the team at UCLH. This is a team approach. I'm just representing us today, the MS Society and the Neurology Academy, who are trying to support this.
And what we will do, we'll download the chat, and I'm saying that to Hugh, so we download the chat and we will try and get some of those questions answered and put up onto the Neuro Academy and probably the MS Society website, so that some of these questions can be answered in the ongoing basis, because we do realise this is an issue probably in most areas of the country, but if we take a national approach to it, it will help, and we can all work together to get this sorted, so our patients benefit. So thank you all. Have a nice lunch wherever you go.
Thank you.
Thank you.